Chris, just give me a thumbs up when you think we're ready to go. Thumbs up. All right. I want to welcome everyone again to the CSI Pacific Concussion Update / Workshop. This is just an opportunity for staff in summer sports and all sport staff, actually, but CSI staff and all sport staff to become familiar with the changes in the concussion consensus guidelines that were published this summer after the meeting last year in Amsterdam. So today's presentation will take two forms. The first will be a 1 hour presentation by Dr. Brian Benson. Brian's in Calgary right now, and he's going to zoom in, and I think he's on your screen. And then there'll be a short break, and then we'll have a second workshop presented by myself, designed to highlight the differences between a concussion guidelines and a sport-specific concussion protocol for those sports that may need to tinker or update their sport protocols after the concussion update. So without further ado, I'm going to take this opportunity to introduce Brian Benson. So Dr. Benson is the CMO of CSI Calgary, the current CMO for Luge, Bobsleigh, Skeleton Canada, and for Ski Cross, and he's the medical director of the Benson Concussion Institute. He is the lead author on the Hobson High Performance Sport-Related Concussion Guidelines for the Canadian National and National Development High Performance Athletes. And he was present in Amsterdam for the consensus meetings last year, and is going to provide this update from those meetings for us all today. Thanks, Brian.
Yeah, thanks, Patty. No, it's a pleasure to present to everybody today. I'm just going to share my screen. Oh, I think, Patty, it just says host disabled screen sharing. Just gotta.
2 seconds, Brian. Chris is just working on this in the back. Yep. It should be, I'm getting a thumbs up, Brian. Let me know if things have changed on your end.
Okay. Yeah, that's better. Okay, can you see that, everybody?
Yep.
Okay, so over the next 45 minutes, I'll be giving a presentation on the new sport-related concussion guidelines, and particularly what's new and how it affects us in high-performance sport. So as Patty alluded to, I'm in Calgary right now, and it looks kind of like this right now in the fall with our snow in the background. We're probably not quite as green here at the current moment, but just give you an idea. The Canadian Sport Institute, Calgary, I'm sure many of you have been here. We're at the Winter Sport Institute, formerly Canada Olympic Park, and where we have the sliding facilities. We got 4 arenas, one Olympic size, the ski park, and the former ski jumps, and the high performance training center for our national athletes. I'm very fortunate. We have a performance medicine clinic and rehabilitation clinic here in Wind Sports. So we're right next to our CSI Calgary, where we service high performance athletes and the concussion community at large. I don't have any disclosures today as it pertains to this conference here, other than I'm a founder and medical director of the Benson Concussion Institute. So over the next 45 minutes, I'll just briefly go over the epidemiology, define concussion and what's new, go into assessment and management, prevention strategies, talk about retirement from sport considerations, dive into parasport considerations and future directions. So we all know concussion and the current public health concern going on globally. In Canada, sport's the leading cause of concussion in youth and young adults, and it comprises 60% of concussions in children and adolescents. There's a 1 in 5 lifetime risk of concussion, over 160,000 brain injuries annually, and the economic impact of this injury from direct and indirect costs is quite staggering. So defining concussion, in its broadest clinical sense, it still is a brain injury induced by a traumatic impulsive force transmitted to the brain. As Patty alluded, the International Consensus Conference occurred in Amsterdam in October 2022, and the guidelines were published widely in June of 2023. So a lot of this discussion will pertain to the current evidence. So an updated definition, and highlighted in yellow are the changes from the previous consensus statement. So it's caused by a direct blow to the head, neck, or body, resulting in an impulsive force transmitted to the brain. It initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation affecting the brain. Signs and symptoms, they can present immediately in a lot of cases or evolve over minutes to hours and commonly resolve within days. It may or may not involve loss of consciousness, and there's typically no abnormalities seen on structural neuroimaging such as CT and MRI scans. The abnormalities may be present on functional blood flow or metabolic studies, which are emerging, and there's been a lot of research on this over the past several years. And the clinical signs and symptoms cannot be explained solely by, but they may occur concomitantly with drug, alcohol, medication use, cervical spine injury, peripheral vestibular dysfunction, or other comorbidities such as psychological or other medical conditions. So it's pretty similar with the additions in the yellow. And what is new, there is a new operational definition of concussion. And I think this provides some value add for clinicians working in the DTE, as it provides some, direct criteria that you can base clinical decisions on. So it's been published by the American Congress on Rehabilitation Medicine in 2023. And it's based on evidence reviews, Delphi method, and international consensus. So the first criteria, there has to be a mechanism of injury or a transfer of mechanical energy to the brain from external forces. Secondly, there should be one or more clinical signs, and these can include any of the following: loss of consciousness. Some clues of this: no protective action on falling, lying motionly, or unresponsive. An alteration in mental status. They can be either slowed or agitated, can't follow two-part commands, disoriented. Can be complete or partial amnesia, or other neurologic signs. And sometimes you'll see some tonic posturing, seizure activity, or motor incoordination upon standing. Criteria 3, there should be 2 or more new or worsening acute symptoms. And they can, they're pretty broad, but they can be acute subjective alteration in neurologic function, confusion, disorientation, or dazed. It can be physical symptoms, and we all know the long list: headache, balance, dizziness, nausea, sensitivity to light and noise are some. It can be cognitive symptoms: slowed down, difficult concentrating, mental fog or memory problems. Or there can be emotional symptoms, which are uncharacteristic to the individual. Criteria 4 is clinical exam and laboratory findings, and these should meet standards of reliability and diagnostic accuracy. So on clinical exam, there should be some demonstrable cognitive impairment, balance impairment, oculomotor impairment or symptom provocation in response to testing. And then elevated blood biomarkers were inserted into this criterion, but certainly none were recommended at this time as based on the lack of evidence to a certain acute concussion. So it's important to note the impairment is defined as a clinical meaningful discrepancy between post-injury test performance and either age-appropriate normative reference data or where available pre-injury baseline test performance. So there should be some change. And if you have the individual level, that's the better. And neuroimaging, it's not necessary to diagnose concussion, and it's used to rule out a head or brain injury that might require neurosurgical or other medical intervention. If there is imaging done and there is an abnormality shown on imaging, it's indicative of traumatic brain injury, and this is not concussion. This is structural brain injury. And the last criteria, it shouldn't better be accounted for by confounding factors. And some of these may be pre-existing or co-occurring health conditions determined to be not fully account for the clinical signs, symptoms, examination, or lab findings necessary for a clinical diagnosis. So it could be musculoskeletal pain, psychological trauma, alcohol or substance intoxication, can be cardiorespiratory etiology, syncope prior to the fall. It may involve medication use or neck injury, a vestibular injury, or other post-traumatic stress disorder in the acute setting, or pre-existing health conditions that can influence the validity of symptom reporting or test results. So it gives a nice operational definition. So we are finalizing, hopefully this week, these will be available, and they're the COPSI Network High Performance Sport Concussion Guidelines, and it's an update on the current standard of care for high performance athletes. So moving on to assessment. So first, baseline assessments. So why are these important in high performance athletes? So I'm just going to highlight some of the key considerations here, and hopefully I'll demonstrate why in high performance sport they're pretty important. So first, there's a lot of challenges to assessment. There's no single gold standard diagnostic test. Evaluation, diagnosis, and management is complex, it's dynamic, it's multidimensional. It's a diffuse brain injury. So there's many different signs and symptoms. There can be balance deficits, psychological or cognitive impairment, sensory motor changes, vestibular features. There can be visual deficits, auditory impairment, the neck's typically involved, and there may be autonomic nervous system dysfunction. And there's the potential for many pre-existing or coexisting pathologies such as migraines, anxiety, depression, ADHD, or learning disabilities, visual disturbance, hormonal influences, previous concussion history, chronic neck pain. They can have disordered sleep, and certainly the para-athletes have several particular neurologic impairments that all can influence or confound concussion-like symptoms or signs. And then there's the challenges to assessment. So we know there's very individual athlete variability or normative data, and it's age specific. So you don't want to be comparing pediatric norms to adult norms. On the far right, there's an example of reaction time in athletes and non-athletes, and it's significantly different. So you don't want to be using normative data, comparing it to high performance athletes if you're using reaction time as a measure. There's sex and gender differences and norms, language, ethnicity, and cultural norms. There's different types of sports, whether it's team or individual. There's contact, collision, combat versus speed or technical sports. There's parasport athletes, each of which will have a different normative data set for these athletes. There's the effects of previous concussions, the comorbidities that we discussed previously, the Paralympic athlete. So each athlete's unique with a different set of physical, cognitive, and social attributes that may influence concussion and their recovery from concussion. And there can be subtle deficits. So we all know that high performance athletes, they're resilient. They're a survival cohort, and they have an innate ability to adapt secondary compensatory mechanisms to injury. If concussion's missed, it may have dire consequences in a high-risk sport context. So it's now established that the risk of lower extremity injury is significantly higher at 6 months to a year post-concussion. And then there's always athlete cover-ups. They often want to return to sport quickly, especially if there's an important competition come up or Olympic qualifier. They all miraculously are 100% and want to be cleared to return to sport. So if you don't have objective measures, or if you're not measuring things, it's hard to ascertain whether they're actually recovered from their injury and safe to return to play. And now it's thought there's no more clinical recovery. It's physiologic recovery from this injury. So typically what we mean by this is the window for physiologic recovery may outlast their clinical symptoms. So on the far left, if you baseline an athlete, they have a concussive event, they usually have some concussion-like symptoms. If you see them in a clinic and do some testing, there's some abnormality demonstrable. Then they go through this subacute phase where their symptoms subside. Clinically, you do your assessment and you say, geez, they're normal. But then if you measure some of the multimodal physiologic systems, you can still detect impairment in some individuals. And for full recovery now, we mean they're asymptomatic, they're clinically normal, they're physiologically normal, and not at rest. It's with activity at their levels of required for competition, and with cognition and back to normal life. So why baseline? So certainly the new operational definition defines impairment as a clinically meaningful discrepancy between post-injury test performance and either age-appropriate normative reference data, which we don't have in high-performance athletes, or where available pre-injury baseline test performance. So for our high-performance sport-related concussion guidelines, we are recommending baseline or pre-injury neurologic assessments to all high-risk athletes, summer and winter and para at the national and national development level. And certainly this entails a medical history, looking at previous concussions and other potential comorbidities that can influence or confound the concussion type symptoms and recovery. We're recommending some validated screening questionnaires around anxiety, depression, and sleep. And these are things typically impacted by concussion. The Sport Concussion Assessment Tool, and now it's SCAT-6. There's a new version of this. An assessment of vision, vestibular oculomotor systems, and these can entail visual acuity. King Devitt is commonly used, vestibular oculomotor screening, or the VOMS. A measurement of orthostatic vital signs, and these are blood pressure and heart rate response to lying supine and standing with associated symptoms. Some cognitive assessment, which may include web-based assessments in a distraction-free environment. And certainly the common one being used is impact, but there's other neuropsychological test measures there. And it's recognized that web-based testing has cost and resource implications, and should not take precedence over programs to provide clinical care. So all these baseline assessments recommended can be done in the clinic by a trained technician or part of the paramedical team. So moving on to on-field assessment. So certainly an algorithmic approach is recommended. So standard emergency or first aid principles are paramount. You assess for any red flags requiring immediate off-field assessment or transport to the emergency department. And some clues include a visible skull deformity, vomiting, a Glasgow coma scale less than 15, if they're increasing headache, they have seizure activity, deteriorating or loss of consciousness, double vision, neck pain with weakness, numbness, tingling, burning to more than one limb. And these are all certainly on the concussion recognition tool version 6 listed on those. Should assess for some observable signs, the C-spine, coordination, oculomotor, and memory questions. And this gets at ascertaining C-spine immobilization or boarding, immediate off-field transport for assessment or transfer to the ER. The new SCAT6 has a nice operational algorithm here with regards to what I just said. So certainly if there's red flags, it goes yes, no, and it's really algorithmic here. So if they have any of these observable signs or features that require transport to the emergency department or immediate removal from the field, where you can assess them in the medical room. So I'd have a look at those if you haven't seen those already. If they're determined stable enough to assess off the field, then certainly SCAT6 should be employed in a distraction-free environment, such as the locker room or a medical room, rather than on the sideline. So the greatest utility for this is in the first 72 hours and up to a week following the injury. And it's important to note the SCAT6 is not a standalone method to diagnose concussion, measure recovery, or make clearance decisions. Athletes can score normal on this and still have a concussion, so it's certainly considered an evolving injury in the acute phase. If they're suspected as having a concussion, then certainly they should be seen in the clinic. And certainly, as stated previously, clinicians lack a single gold standard assessment tool to reliably and objectively diagnose a concussion. It's certainly a multimodal neurologic assessment here, and based on the operational definition I described earlier, that can certainly be helpful in making a clinical diagnosis. After 72 hours, the SCOT6, so that's new this year. It's called the Sport Concussion Office Assessment Tool, should be used for serial multimodal assessments in a clinical setting. And still, the diagnosis remains a clinical judgment with the aid of history and the assessment battery. So the SCOT6, this is what it entails. So a timed 10-word recall of digits backwards and digits backwards, orthostatic vital signs. So as we alluded to at baseline, it's a blood pressure and heart rate response lying supine and then standing with the documentation of symptoms. It includes cervical spine evaluation, neurologic examination, balance assessment, and time tandem gait, noting any inability or unsteadiness. There's a modified vestibular ocular motor screen, a delayed word recall, a minimum of 5 minutes after completion of the immediate memory, computerized neurocognitive test batteries. They are recommended to add value where available and resource dependent. There's an assessment with validated anxiety, depression, and sleep screening tools. And there's the option for complex tandem gait and dual tasking, but with tandem gait and the choice of 3 cognitive tests. So it's much more comprehensive than the SCAT6. So on to management. So as the previous consensus statement, the initial 24 to 48 hours should include relative rest, not absolute rest. So no longer are we recommending going to a dark room and lying there for, lying in bed for a series of days. We want to get them active and get them moving, but as long as it doesn't exacerbate their acute symptoms or put excess stress on the brain energy demands in the first 24 to 48 hours. So you should minimize any visual or auditory stimulations, such as electronics, smartphones, computers, or television, and try to maintain hydration, snacking or meals, and sleep optimization. After the initial 24 to 48 hours, they should be encouraged to become gradually and progressively more active. And certainly there's been a little update to the return to learn and return to sport strategies, and they're documented in the consensus statement. So with these, low risk physical or cognitive activity should not bring on new or worsen existing symptoms more than 2 out of 10 for more than an hour. And there's strong evidence for the benefits of physical activity and aerobic exercise as early interventions. And if there's any neck pain, headaches, dizziness, or balance issues, then cervical vestibular rehabilitation is indicated early. Based on the multimodal assessment, vision therapy, psychotherapy, and exercise prescription may be warranted. And athletes should only progress to stage 4 of the return to sports strategy, which is your more higher risk stage, when they're asymptomatic at rest and with exertion, when they have returned to full-time school, and any abnormality demonstrated in the clinic has returned to normal. So each athlete's concussion should be individually managed based on the treating physician's clinical judgment, and there should be written medical clearance to return to unrestricted sport participation. So for high performance athletes, we're recommending return to unrestricted training or competition when the 4 criteria are met. And there should be a complete resolution of concussion-related symptoms at rest, no recurrence of symptoms at exertion levels required for unrestricted training and competition. When the athlete's post-concussion neurologic status has returned to their individual baseline level as judged by the physician. And when the athlete is confident to progress, has been educated about the elevated risk of recurrence, and risk reduction strategies have been met. A few return to sport statistics here. On average, 13 to 18-year-olds return in 20 days, and greater than 18, around 17 days. So when they're seen early with intervention, targeted intervention administered if needed, then certainly they recover most individuals, within this 3-week time period. About 20 to 30% of athletes will experience persistent symptoms, and these are defined as symptoms lasting longer than 4 weeks. And really, this may not reflect ongoing physiologic injury to the brain. In some cases, it does, but this is where it requires a comprehensive, multifaceted clinical assessment with targeted management to the specific medical, physical, and psychosocial factors identified from the assessment. The targeted management may involve one or more of the following healthcare specialists for athletes having persistent symptoms. And certainly the therapists become really important, certainly on the neck and the vestibular system, the visual system if it's involved, and there's certainly good neurooptometrists or ophthalmologists. auditory. We may need an audiologist for chronic tinnitus or hearing conduction concerns. Sleep specialists sometimes need to be involved. The physiologist from if there's exercise intolerance or autonomic dysfunction. Certainly the psychologist, if there's any mental health issues become important, and in some cases psychiatrists need to be involved, and neuropsychologists. And then if there are persistent headaches that are complex, or if there's any structural brain injury, certainly the neurologist and physiatrist can be an important part of the team. And this slide just shows the persistent symptoms. There can be a lot of primary and secondary pathologies that can be mixing up, confounding their symptoms. So certainly there's a lot of brain processes and neurologic systems that can be involved here. So you got to be cognizant of this in anyone with persistent symptoms. And this busy slide is showing some of the targeted management strategies, the differential diagnosis for each one of these impairments. So there's a lot of different things that can be involved, and certainly someone experienced with concussion with these persistent symptoms in a high performance athlete probably should be involved relatively early if they're 4 or more weeks, just for targeted directed assessments and treatment strategies here to optimize their recovery. So for persistent symptoms, there's no recovery trajectories. Certainly we try to get them back as quickly as possible with active, individualized, and targeted rehab in a multi-dimensional collaborative care model. Exercise is deemed to be very important for athletes with persistent symptoms, and they may need more targeted exercise prescription based on an autonomic assessment. So on to prevention. So this slide, I don't know why it's supposed to be an animated version of this. It's showing it everything I think on your side, but I'll just go over this anyways. On the far left, there's the predisposed athlete. So there's modifiable and non-modifiable intrinsic variables within any one athlete. And certainly those that are modifiable are in red and they're circled there. Then they're exposed to the environment or playing surface. And these are extrinsic to the individual. And certainly things like environment, equipment, playing time, rules and officiating come into play, which are modifiable. Those two conditions make an athlete susceptible to injury. And in most cases, they play and train and practice and there's no concussive event. But in some cases, there's a traumatic mechanism that can lead to a suspective concussion. It's either recognized or not. And if not, the athlete continues to play or they go back into that playing environment, and you can appreciate the whole different level of risk if they're in a concussed state and they're in a high risk sports setting for further injury or other injury. If they're correctly recognized, then they're removed from participation. They're correctly diagnosed. They go through a targeted rehab and return to sports strategy. And then they're cleared. In a lot of cases, it's clinical recovery, and those that measure physiologic recovery make a more precise certainty to the athlete for clearing them to unrestricted sport. Then they go back into the playing environment, and you can appreciate the dynamic nature of risk, because depending on the length of time it takes for them to recover, or their psychosocial impairment, their neck can be involved. They can become deconditioned, their aerobic capacity down. They may have visual abnormalities. The nutrition may not be as good. So, it can predispose them with a whole different level of risk. And we now know that if previous concussion history increases the risk of future concussion. So, risk reduction strategies are of paramount importance. So based on the evidence, there's some extrinsic risk factors that we look at in terms of risk reduction strategies. So certainly as it pertains to equipment, we have helmets in cycling, skiing, snowboarding, equestrian, and motorsports that are shown to be beneficial. Headgear in adolescent soccer, mainly over in Europe, has shown a 36% risk reduction. Full facial use in ice hockey, reduced time loss in ice hockey. Mouth guards, now a 28% risk reduction in ice hockey. With respect to policy, body checking, 58% risk reduction in youth ice hockey. Limiting contact practice in American football, 64% risk reduction in practice. And then artificial turf versus grass. So a 40% risk reduction on grass versus artificial turf. With respect to intrinsic risk factors, neuromuscular training, a minimum of 3 times a week, particularly in a warm-up in rugby, is shown to reduce risk 32 to 60%. Neck strength is trending. So certainly weaker mean strength in high school soccer, basketball, and lacrosse athletes have shown to be a higher risk of concussion. Again, this wasn't a statistically consensus risk reduction strategy, but it's trending. Same with vision training. Again, trending. Preseason training program in collegiate football at reducing risk. And collision anticipation, reducing head impact severity in youth ice hockey, is trending as well. Secondary prevention, so a policy mandating optimal concussion management, which requires removal from play, timely medical assessment, and medical clearance to return to sport, is shown to significantly reduce recurrent concussion rates. So moving on to the long-term effects. So this certainly was an area of a lot of public concern, obviously, and then the medical and the public health interest. And certainly at the Amsterdam consensus statement, it was a very emotional debate with people in the audience and people highlighting the ongoing concerns around chronic traumatic encephalopathy. But so the potential long-term effects of sport concussion and repetitive head impacts certainly are an area of great concern. To date, studies are methodologically limited because most were not able to examine or adjust for the many factors that can be associated with the mental health and neurologic outcomes of interest. And there's a long list here. And these include genetic factors, educational attainment, socioeconomic status, smoking, hypertension and cardiovascular disease, diabetes, sleep apnea, white matter hyperintensities seen on MRI imaging, social isolation, their diet, physical activity or exercise. So there's a lot of factors that may be part of that, part of the causal chain on neurodegenerative changes over time. So it was recognized to establish a clear causal association between sports participation early in life and cognitive impairment or dementia later in life, or to quantify that association. Certainly future well-designed case control and cohort studies are needed. And they're needed to include as many of those risk modifying or confounding factors as possible before we're going to really, truly determine a causal association between sport and development of these entities. So with respect to CTE, no cohort studies of former athletes with CTE that can examine causation or quantify risk are out there. So they weren't included in the 2022 systematic reviews. They do give a statement here. They do say, though, it is reasonable to consider extensive exposure to repetitive head impacts, such as that experienced by some professional athletes, as potentially associated with the development of the specific neuropathology described as CTE, neuropathological change. So much more needs to be done in this topic area. So retirement. This is always a difficult one with high performance athletes with repeat injuries. So decisions certainly based on a comprehensive, multidisciplinary clinical evaluation led by a physician experience with both sport-related concussion and high-performance sport are needed here to make any decision like this. The decisions are complex. There's certainly no clear evidence on how many concussions are too many. There's no absolute patient-specific, injury-specific, or imaging-related evidence to base any decisions. Certainly, there's a need for individualization on this topic, and it should include athlete preferences, their confidence and readiness to return to sport, the type of sport they're playing, their risk tolerance, their style of play, whether there's a threshold effect. And what I mean by that is with each successive concussion event, if it takes less force to create more symptoms that take longer to recover, if you see a pattern evolve there, then the red flags go up about a diminishing threshold effect to either take or give a contact. The social-cultural effects, the ethical considerations, psychosocial factors, and certainly their family members and significant others should be included in any decision-making strategies around this. In parasport, so this was certainly an area that was recognized as that there is little evidence to support any of these guidelines. And it's certainly because there's a wide range of impairments among parasport athletes, and clinicians face the difficulties when applying traditional assessment tools to para athletes where they're not validated nor applicable in many respects. So without reliable and sensitive assessments of neurologic function, certainly in this population, it's difficult to prescribe effective intervention therapies based on their individual pathology. So much more longitudinal prospective research has to occur in this population, and certainly our parasport athletes, there needs to be some customization involved. So in recognition of this, annual preseason baseline assessment certainly become essential, depending on the type of disability. And as I stated, there's a need for prospective longitudinal research on this in this area, particularly in high performance athletes, to establish baseline normative neurologic function with different disabilities, develop objective, reliable, and valid multimodal baseline and post-concussion assessment tools customized to the type of disability impairment, and to assess the effectiveness and management strategies that are targeted and individualized with different impairments, and then prevention strategies. Future directions, there's certainly a lot more to do. As you can see, there's some changes based on the previous iterations. There's been a lot of research on this around the world, but certainly we're not definitive with what we know. There's the more you know, the more you don't know, and that's certainly with concussion, which is such a diffuse injury. So more research on wearable sensors. The technology is certainly rapidly developing. We got to ensure that they're reliable and valid and measure what they're intended to. Robotic assessments, biomarkers, virtual reality combined with artificial intelligence, long-term effects, and CTE specifically. More research needed. Children 5 to 12 years of age, very little evidence, and parasport athletes, very little evidence to make any recommendations. So those were the areas considered in need of further research. So thank you for your time, and I'm happy to take any questions.
Great, thanks, Brian. I'm going to monitor the chat here in case people online want to send questions into the chat. So just maybe start here in our lab in Victoria, if anyone has any questions they want to shout out.
First of all, Dr. Benson, thank you very much for your presentation and your insights. It's Kurt Innes here with CSI Pacific. I'm keen to hear your perspectives on medically cleared versus performance ready, and specifically my interpretation. So medically cleared, there's no objective clinical findings, whereas performance ready, the athlete would have to demonstrate some sort of capacity to perform at the requisite international level if we're talking high performance. So my question specifically, within the assessment phase, and then transitioning into this management phase, how could or should sort of the technical, tactical expert feature in the return to sport protocol and plan? And I mean like sport coach or technical coach or tactical coach. How would you sort of marry that together and insert that into that management phase?
Yeah, that's an excellent point. And I think the biggest thing, they're completely different, right? From a sport concussion pure clinical basis, where we get concerned about recovery and determining recovery to be involved with high performance sport. But then, the readiness to return to sport becomes a whole different animal here. And I think this is where, if a clinician clears someone and they determine, okay, they're cleared to our best ability, they can get into high risk training environment. Certainly, then it becomes, I think, the people who know the specific sport the best, the NSO and the technical leaders in this area, the strength and conditioning, the coaches involved, all your IST performance staff. So there's certain metrics you probably want to see to be able to establish readiness to compete, and there's certainly there's the psychological readiness to compete. A return, and there are scales for that to establish that. But performance metrics, I think it's too hard to do at a global level for every sport, because they're all different. But at an individual sport specific level, this is where I think there can be a lot of leeway and expertise to help guide their readiness to return to actual competition. And there's no right or wrong answer, but you may have benchmarks, just like you would for an ACL injury or a shoulder injury coming out, whether their range of motion, strength, performance, and agility, and then their endurance or rate of force development. If you have targeted measures there, then you want to achieve that. I think you leave that with the technical and the tactical expertise of an NSO. I think from a clinician perspective, you want to make sure that they're cleared to go into that high risk setting, and where it can be as comprehensive and complex as you can make it. But I think that's got to be an individual level and readiness with the IST team to return, if that makes sense.
Thank you, Brian.
Yeah, thanks, Brian, again for great presentation. If you're okay, I'm actually going to ask a couple of questions that were asked at the last presentation, because I think they're good questions for everyone to hear your response to. And so the first one I'll ask, recall this one from the first presentation, is, you referenced nutritional interventions. Can you just give a summary right now of what are the current best evidence nutritional interventions for people, either prevention of concussion or treatment for people with concussion, acknowledging the evidence isn't rock solid out there, but where are things trending?
Yeah, nutrition's a good one. It's around brain energy reserves, around the cognitive processes and neurologic processes. And it's hard to assess this or establish this at the microscopic level, as you can imagine, from a research perspective. But the ones that are certainly trending, the omega-3s, and particularly the DHA around cognition, and higher doses of the omega in the acute recovery period if you're not worried about a bleeding risk. So 2 grams, certainly a day. And then you got to take your age effects into that if they're really young. But your vitamin D exposure, and certainly thinking about vitamin D and its effect on calcium and absorption, moving intra and extracellular and energy systems. So vitamin D certainly, and in a little bit of higher doses, has been shown to be beneficial in some early evidence. And it makes sense physiologically with concussion. Calcium's toxic on the brain cells, so we're trying to move it intra and extracellularly as best you can, and vitamin D can have a component part of that. Branched chain amino acids are emerging. Certainly some animal evidence is out there on branched chains, no human evidence yet, but showing some promise. A multivitamin, just some of your trace minerals that may not be in your diet, your zincs and other minerals there. Turmeric is trending. It's an antioxidant, as you all know. It's good for a lot of different things, but trending for the brain. And then things like, depending on if they're headaches, and particularly migraine susceptibility, if they have a predisposition to this, your coenzyme Q10, magnesium, and there's different types of magnesium. It can help with sleep, mood, and headache control at specific doses. Then you think of vitamin B2 or riboflavin too, having some cellular benefit for post-traumatic headache in some individuals. Melatonin for sleep, certainly safe. It just puts them in a deeper form of REM sleep. So certainly a low dose an hour before bed, and limiting their bright light exposure during that period if they're having sleep difficulties. Those are the big things. If you're doing a lot of supplements, the value out of a probiotic too in there. So those are the ones that are emerging anyways. I hope that helps. I can't say anything definitive, and the nutritionists in the room can probably correct me from some of those, but that's my understanding from a clinical basis.
Yeah, thanks, Brian. That's great. And I think just a good reminder that while the evidence isn't there, or like say rock solid, there's still some low risk interventions that people could undertake, particularly early on. Now, there is a question from the chat from Dominic. Could we briefly discuss the introduction of the Q collars into high impact sports? Is there evidence backing up these devices? Any dangers with disrupted venous flow?
Yeah, it's a great question. And I think we get that a lot about Q collars and the potential prevention. And certainly the studies on Q collar are shown at the imaging level. So changes in white matter hyperintensities. So certainly there's been what I understand, no evidence of risk reduction with the use of a Q collar. And with venous restriction, you think the theory of retention of fluid in the brain will give some better shock absorption, but the understanding, right? If you're affecting blood flow, and you just think of some of your sports, if there is an aneurysm or some susceptibility, if they have connective tissue disorder, or a little fragility to the vasculature, if you're certainly affecting blood flow and venous return, and you're getting G forces involved in a lot of intracranial pressure involved in blood pressure changes, you just worry about risk, right, of vascular disruption there associated with it. I haven't seen any in the literature associated with it, but I think a neurosurgeon actually was the one who developed this technology, but certainly had no evidence of risk reduction on the playing field.
Great, thanks, Brian. I'm going to ask, this is a question that came up. I was on a call with other clinicians working with concussion, and we were talking about the new SCOAT and where the delayed recall was positioned, in the SCOAT compared to where it sits in the SCAT. And it's much further down. So there's a longer delay between when people finish the immediate recall and when they start the delayed recall. And I just, put you on the spot here, your thoughts on, because I noticed you said like a delayed recall of at least 5 minutes, but what people are finding, it might be 30 minutes before you get to the delayed recall, just based on where it is on the SCOAT. And so we had this question of how long is too long, where the delayed recall, you get some just affects that it's too long a recall versus, and so any thoughts about that? Like, should we be timing when you finish it so that we roughly know when to do the delayed recall?
Yeah, I think you just alluded to the problems of making any clinical decision making on a scoped, right? And some of these clinical parameters around this, right? What you're really looking for is within that first week of any change from their baseline assessment. And yes, you should note the time for sure. And there's been no studies, right? Whether it's 5 minutes, 10 minutes, 15 minutes, 30 minutes, and what does a change of 1 or 2 really mean? And will it influence clinical decision making? Probably absolutely not. So I think if you're getting outwards of a week, then you're looking at serial evaluation, and I think it's more either symptom based and individualized concerns at that point, right? But I think if you're doing it in 72 hours to a week, you're looking for a change from baseline and to be able to actually make your clinical diagnosis of concussion in any domain. But that one I think would be probably lower on your spectrum to make a make a clinical decision on.
It sounds like really the response is as long as it's consistent from measure to measure, whether it's 5, 10, or 30 isn't the biggest deal.
Yeah, I would agree.
Is there any standard around how often baseline should be done? So I'm thinking like over time. I mean, you mentioned it in the para sport, do an annual baseline, but what about just able-bodied athletes? Is it 6 months, a year, every 2 years?
Brian, any thoughts on the timing or the frequency of baseline testing?
Yes, certainly we're doing research. We're in our 13th year of doing prospective longitudinal research with multimodal testing, and certainly the age effects are very, very, very clear. And particularly if you're doing children and adolescents, right up until around 18, 19 years of age, and then they start stabilizing. So annually, every year for those younger athletes is recommended, because you don't want to be comparing a 12-year-old to a 15-year-old, because there's definite age neurodevelopmental effects in a healthy state. So you want to get them in that year, every year in their year of competitive season. When it gets after that, certainly I think just due to the effects of high risk sport and their survival cohort in the high performance network, I think they're getting a lot of subconcussive loads and forces going on. So, it's a way to monitor. And I think if you've got resources, you've got an IST that got a team of individuals that are really concerned about the health and well-being of the athlete and their performance metrics. I think doing that in that population is important as well. So I'd say annually. And baselines, the term baselines, it's used loosely around the globe. And I really don't think we should just be baselining to baseline. And you see that happening all over, and people are charging to baseline. I really think the only value of baselining is if they're part of a comprehensive program with a support team that can monitor them and a certain impairment and a clinical diagnosis and a certain getting them back healthy and ready to compete. And that's where I think high performance athletes, it's a program, and baseline is just one component of their high performance program that's, I think, of critical importance for their health and well-being. We know 20% of these athletes are going to get a concussion every year. So I think we got to take care of them.
Yeah, thanks, Brian. And that question was from Dave Hill. Another question here from Victoria from Trent Stellingware.
I'll move up so you can hear me better. Thanks, Brian, for a nice talk. I wanted to ask a little bit about the chronic outcome. And it's a bit philosophical, as a few of us have just written an IOC consensus on REDS, which is also a chronic outcome. And you mentioned CTE, and it was barely mentioned in your consensus. And I'm wondering, on the expert global level, is there acceptance that it exists, or that it's just confounders and moderators? And because obviously absence of evidence isn't necessarily evidence of absence. I was just curious as what the real experts debated and whether CTE actually exists, or is it just a figment of moderating factors and other elements?
Yeah, it's a great question. I think it's just that it's causation. And as you know, it's, does concussion cause CTE, and how many subconcussive blows or true concussive events lead to that entity is the question. And just research hasn't been able to answer that, Trent, conclusively, right? There's certainly associations. Yes, you see it. And I think all those potential comorbidities and other factors that can contribute to chronic neurodegenerative disease or the CTI entity itself. There's just so many variables, and I think it's a brain autopsy. When they pass, that's the diagnostic pathological. So I think prospectively in time, you got to have a control cohort and an injured cohort, follow them forward, and it can take decades controlling for all those variables, and then really truly association as part of the causal chain before we're going to find that out. And I think that's what there was nothing to base a systematic review on in this current consensus, particularly to that. But yes, there's the association that's happening. It's real out there. And where does sport contribute to that, and specific concussion and subconcussive blows? Where does it contribute? Part of that causal chain is yet to be alluded to, but yes, it's a real concern. And I think that's why we want to look at making sure everyone's seen, they're taken care of, they're recovered to our best ability, and they're understanding the risk of future participation on this, and they know it at that level, because there's a lot we don't know around that topic. So it can't be conclusive, but I think that's why it's such a concerning topic. Uncertainty around it, right? And nobody likes uncertainty.
Thank you.
Brian, I'm going to ask another question that was asked at the last presentation, and it's about the return to learn and return to sport. If someone had asked, because based on the current guidelines, the recommendation is for 24 to 48 hours of relative rest, and then depending on how people are feeling, they can begin a return to sport, potentially a return to learn. But I'm wondering if you could just comment on, is there a threshold that you want symptoms to be below, before you clear someone at 24 or 48 hours? Like sometimes people may have, minimal symptoms, at 12 hours or at 24 hours, or they may still have a lot of symptoms at 48. So just any guidance on when it's okay to progress, versus probably more my question is, when should we be maybe more conservative?
Yeah, I think the evidence around this is irregardless of symptom profile, you want to start them establishing normality and get some load going through their brain from a blood flow or a cognitive level, as long as it doesn't flare them up, right? More than 2 points, so 3 or more out of 10 on a 10-point scale. If it's 1 or 2, the theory is that neuroplasticity concept. So you need stimulus to adapt. And if you don't, you're going to get more chronically in a state where you get sensory upload. So you're more sensitive to little changes in your environment. So the longer you're in that state, when you do introduce some sort of activity or real life cognitive load, then you're going to be more sensitive to the changes. So you want to start them early and just use that, 3 or more out of 10. That'd be too much load. That means let symptoms subside and then start again at a lower level. But you want to get them moving early. You want to get that brain turned on cognitively and get them going to respond and adapt quickly.
Great.
But in a controlled, low risk manner.
Yeah. So it sounds like consistent with the general trend over the last couple of decades, getting them moving early is still considered a good thing.
Yes.
Great. One more question from Dave Hill.
Can you hear me from there? Or do I need to get closer?
Sorry, I can't hear that.
Curious about, it's actually a 2-part question, but around the history when you're doing history of concussion and you're looking at either the frequency of prior concussions or the time period between the concussion previously. So what's more important? And then that comes back to a more global question around tracking. So, you know, when we're looking at athletes in a pathway, they don't just emerge in high performance where all of a sudden we can track them. What are some of the recommendations around how we can get this either into their medical record or other bespoke data options, of which there's thousands out there probably? So the first question is just that, is there the concern around either frequency or proximity to the last event? And then how do we track or do a better job?
Yeah, it comes down to monitoring, and I'll get at that one first here. But you know, I do think the baseline assessments, there's depending on your level of assessment. That's why we're trying to standardize it in high performance sport at the minimal level, not based on a lot of technology. If they don't have it, but at least get those measures we recommended and track them, and those should be included into the monitoring piece that with other metrics from strength and conditioning coaches or psychometrics, right? Or functional screens. I think they're all component of our monitoring, right? It's part of the intake process that we're trying to establish when we truly understand baseline for that particular athlete from mental and physical and biosocial aspects, then we can monitor them going forward in time. If they have a concussion or not, I think it's going to be valuable to try to screen and detect early impairments and get them back to health and performance as quickly as we can. The frequency of concussion, yeah, it's a hard one, right? The proximity back to back to back. Certainly, it's not a good thing. We don't know how many too many, and we don't know what the proximity is before we should be more conservative on their timeline to return to high risk sports. So that's where I think establishing a certainty around physiologic recovery with some of the outcome measures is helpful, right? Before you establish their readiness to return to performance. So it's not good back to back, but I don't have a absolute to say. I don't have any evidence to say hold them back longer with each successive one in a current year. Monitoring's hard because people are measuring different things. And it's a lot of data, and you got to have a team of data scientists that understand data and how, for the NSO, how to break it down and give them information on an annual basis. But I think you bring it down to the simplest level. I think you need a team involved with that and someone involved if we're truly gonna to move the bar in that space. I think we need some champion that's going to be disseminating and transferring knowledge to the NSO from year to year with what's going on with their health and well-being of athletes.
Great. Well, thanks again, Brian, for a great presentation on the update. I think right now we're going to end this session. There'll be a short break while we transition over to my laptop, and then I'll begin the workshop on concussion protocols for sport. Thanks again.
You bet. Thanks, everyone.
Oh, I got the clicker. 20 minutes. You know why?
Yeah.
No. Oh, you know, obviously just remember watching that.
Yeah. You okay if I go? Okay. Oh, that's my donut.
All right, I think we'll get going on the second half. And in terms of the volume levels at home, there's only one person who actually has their camera on. So I'm going to pick on Laura. I have no idea who you are exactly, and you probably have no idea who I am either. But Laura, if you can just give me a thumbs up about the last presentation about the volume. You heard that okay? Yep. And then right now, as I'm talking, you can hear me okay? Awesome. Great, Laura, you're off the hook. All done. So we'll get going. On the concussion management, this is like the guidelines to a sport protocol segment. And this has been worked on mostly by myself, but some great contributions from Dr. Longland, Dr. Forsyth, the other CSI Pacific physicians. There we all are. Looking, it's certainly about as good as I'll ever look. So the considerations for a sports concussion protocol. So there's a number of templates out there, and you know, a lot of kudos have to be given to Parachute Canada. They spent a lot of effort a number of years ago coming up with a template for community groups and provincial programs, helping to fill a gap, you know, around concussion protocols. Because one thing Brian, Dr. Benson had mentioned is the secondary prevention comes from having good, robust guidelines in the prevent athletes with concussions from going back in before they should. There are other guidelines. Dr. Benson's the lead author on the COPSN sport-related concussion guidelines that's targeted for national teams and national development teams. And I think the comment that he made, and that I'll say again, is these guidelines, they are more specific, and they do talk about some things that aren't in, say, Parachute Canada's guidelines, but they are also for teams and organizations that have a lot more resources available as well. So there's, you know, finances and staffing available to do baseline testing and other testing. And there's other guidelines out there, but they all include the basics around education, prevention, identification of concussions, removal from play, concussion-specific assessments, and return to play guidelines. The point, though, of this particular part of the talk is like there's a difference between guidelines and protocols. And so guidelines, they're consensus statements, they're best practice, and generally they don't really consider what each team or organization might have available to them in terms of staff or funding. And they often read like an educational document. And the protocol, the effective protocols for sports, you know, they should be specific to your sports situation. You know, where's your daily training environment? What does it look like? Who are the staff there? What are the resources you have available? Because there's no point mandating baseline testing for your team if you don't have anyone that actually has capacity to meet your athletes and do the baseline testing in a way that's reproducible from year to year or between athletes. And so, you know, a protocol should read more like a roadmap rather than like a dictionary. And so that any athlete or parent or sports staff would reasonably know what are the next step if an athlete has a suspected concussion. So that's kind of what the intent of the next 30 to 40 minutes will be. And there'll be time for questions at the bottom, but I'm a little bit more laissez-faire. So folks in the group here got some questions they want to shout out. You feel free to interrupt me at all times. We do have a microphone this time around, so hopefully folks at home can hear the questions, and I'll try and be reminded to repeat them. So hopefully this will be a bit more interactive. So our focus today is going to be on Reducing concussions or prevention. Recognize concussions and removal from play. What's the on-site assessment? The reevaluation or the office assessment, and then the return to learn, return to sport. And what I'm not going to do is get into the weeds of what these should be in terms of like what the guidelines are. We just had that from Dr. Benson. More about how to consider how you put these bits, these specific parts into your concussion protocol. Trent, you already look like you have a question. No, okay, sorry. Okay, so reduce, as Dr. Benson had noted, and I don't know if anyone's actually read the guidelines, but it's the 11 R's or the 14 R's out there. So a lot of them begin with R, but reduce is mostly about prevention. So where should this show up in a sports concussion protocol? So this is, essentially the education for those in the sport. And the thing you need to consider is what are the educational materials that are available and who are the intended recipients. And so are you, targeting just the athletes on the team? Are you targeting the athletes and the parents, the sports staff, others in the community, referees, judges, things like that? And how are you going to distribute these to the recipients? Are you emailing a document or a PowerPoint presentation? Are you hosting a webinar or an online presentation? There's a Coaching Association of Canada that got Making Headway, a great webinar on how to learn about concussions and what your role could be in preventing them. Is it an in-person session as part of an early season orientation with the athletes and staff? Can it be part of the athlete agreement, where athletes are signing off on things like their responsibilities and confidentiality around sharing medical information, but also, signing off that they're aware of the most recent concussion updates as they pertain to the sport. Could this be brought up during the athletes' preseason intake? When preseason intakes are being done, and sometimes there's an opportunity during the baseline testing if you have enough time. But I'll just point out to everyone that baseline testing without education takes about an hour, and if you do the bare basics. And so if you're going to have a bit of an education session in there as well, you probably need another 20-30 minutes on top of that. Obviously, it's important that if there are athlete-specific precautions, that those are also in your education documents. So reminders about what are the expectations with head protection or helmets in high-risk situations. And also, there should be a reminder always to staff about enforcing these. There's no point having you got to wear your helmet when you play protocol if athletes are out there and no one's without their helmets and no one's taking them off and getting them to put their helmets back on. And then, I think it's important to consider who's being targeted. As I noted, like it shouldn't just be the athletes. It should be staff, coaches, therapists, admin staff, referees, and even parents. Should be aware of what is the concussion protocol for the sport. All right, I'm not advanced. Oh, sorry. So there'll be these little blurbs where I try and, give you a rough idea, grammar and spelling apologies about, how this can show up in a protocol. So, you're identifying who all athletes on our provincial alpine team and their parents and the coaches. And, it's my belief that when possible, you can even name folks so people are aware of like who the team coaches are, who the team therapist is, who's the team manager. So all these people are going to fall under our protocol, and the pre-season concussion education sheets to be signed by the athletes and returned to the coach. There's going to be a webinar for the staff on this date. And if you can't make it, you're going to let the manager know so we can arrange for another viewing. But we've got a deadline, September 10th, where we want to have all the athletes and all the staff have completed their concussion education. So the next we'll move on to the remove.
I do have a question.
Oh,
prevention.
Yeah.
We're okay to interrupt, right?
Please.
How much in winter sport is discussed with coaches just around periodizing high risk skill development, big air, snowboard, regarding just fatigue? Like, I'm just thinking, you've traveled overnight, you've gone to Europe, you're at Sass Bay, you're jet lagged, you're dehydrated, probably had a couple of beers, smoked a joint, and you're gonna go out. I'm just being honest about our athletes. and you're gonna head out and you haven't been on snow in a month, and to me that is really high risk and a really good thing to think about prevention. Or Dr. Benson around nutrition, like a lot of the injuries happen late in the day. I'm sure blood glucose is lowest in, they probably haven't fueled as well. We know cognitive declines happen with a 500 millimole drop in blood glucose. Is there aspects there that are, I'm not in a high risk sport, so I don't know if those types of ideas and discussions are happening.
Yeah. So that was a question from Trent Stellingworth. And I'll just summarize here, what, from a sports perspective, are they considering some of the higher risk moments in a day or in a week or in a training regimen, like the periodization of risk? And maybe better said, the periodization of risk reduction. How do you address that? Now, I won't speak for the winter sports. And it's too bad at our last presentation, there's a lot of people from Snowboard Canada were there, and they would be able to address it, because they brought it up during that presentation about how they do actually consider travel, time of day, where's the sun in terms of people's visibility as go down the hill. So now I can't speak for sport to sport. And I think, you asked about winter sports, but we might ask the same question about Rugby Canada and, their travel schedule and what players are doing the night before or the morning of, training sessions and stuff. I do know, though, it is important, obviously. And if only based on the question, there are modifiable risk factors day to day, week to week, within a training season, within a competition season. And it's important to, so for those folks out there working in this space that maybe have control over some of these things, these are important considerations for sure. And, Trent, who's, a coach in athletics, and I'll just put this in your realm as well, like dehydration and heat illness and the timing around training sessions, to maximize adaptation to heat or heat acclimation versus avoiding like the heat load that might actually take an athlete out of a competition that's coming up. And not to say there's right or wrong answers, because you need to be available and adapted to the conditions you're going to compete in. But you're managing risk at the same time. So what I would say is it's a great question. And I'm confident at most sports at the very top level, people are considering these things. I think there's always room for improvement. And I think the more you're familiar with the sport and the inherent risk of whatever that thing is, in this case, we're talking about concussion, the more you start to consider how to optimize adaptation and preparation while minimizing risk. And I know Christy's got a...
So I'll just add a little bit. It is a great question. And I think some of the other features that are specifically with snowboard is the coaches are really aware of the athlete's normal behavior, right? So there's always an adaptation phase when they arrive, considering the travel and all that. There usually will be just a get cruisy, get on the hills, just kind of work the kinks out behind the day. And that's the training session before they go into any particular training, right? And so if the coaches are seeing some abnormal behavior, or just, the athlete doesn't seem like their normal self because of fatigue or any other thing, then that's caught pretty quickly, and they'll have that conversation. So I think those simple mechanisms are in place to just work through and just get the best space for that to get on snow. Usually they're not smoking dope.
But I think like bigger picture here, what we're talking about is staff in a sport being aware of risk of a sport. And it's more, this is the warm-up question, like for any sport, like, should you warm up? How long should the warm-up be? How specific should it be? And what it yeah.
All the time, trying to work the biggest tricks.
Yeah. So it needs its own specific preparation, risk reduction. Yep, absolutely. It's a great question. And it's a great conversation. So the next big ticket item in your concussion protocol, is this recognizing concussions, removing athletes from play. And so the latest guidelines do have a great concussion recognition tool. It's got, the visual clues that you are observing to suspect concussion. It's got the symptoms that athletes are going to report, and it's got the red flags. And so I know some guidelines, they kind of refer to this document. And I would just, caution about that, because if these things aren't actually in your concussion guideline or your education thing, I just wouldn't be confident that everybody that falls under your umbrella of following the protocol has gone and read these and are familiar with them. And so I would advocate that these show up right in your protocol. And so, yeah, putting the signs and symptoms in the document, particularly if the document is the education that an athlete and the parent guardian are going to receive. And then I think the key bits around the recognition and removal is you're confirming responsibility of all the team staff who witness a suspected concussion to help with athlete removal. Because, in games or in practices, athletes don't always recognize that they've had a concussion. Like they've bonked their head and they may feel a bit differently, but they're not themselves processing, is this a concussion or not? And so it's our responsibility to help them with that. And, if you're a coach or you're a therapist, you're on the sidelines, you should be involved in, getting the athlete off the field or off the ski hill. But, if you're a parent as well, and you're involved and your kid's on the team, you can, maybe you don't feel comfortable running out onto the field, but you should, talking to people, hey, Billy just hit his head and, we should look at removal. And so it's just important that in the new era of concussion responsibility, that everybody, that's part of the team, including, parents and other staff, admin staff, we're all meant to be looking for observing. And if we see something that's suspicious, we're meant to helping to intervene, whether that's you yourself, go out and remove the athlete, or you're talking with the coaches or the staff, because, in a busy rugby game or a busy rugby practice, you might not see everything that's happening. And then I think it's also really important to put the red flags in the document, because I think if there's red flags you want people to be really worried about and change what the plan is going to be, i.e. we're not going to treat this, on the sideline, we're calling the ambulance. You want people to be familiar with those. And then, can you account for the changes in responsibility based on location? And this is just to acknowledge that if you're at the World Championships, you may not actually be able to get out onto the ski hill or onto the soccer pitch, because the LOC, the local organizing committee, may have responsibility. And they might have actually quite strict rules, as some have found out when they've tried to jump onto the field and been tackled by other staff from the event. So just know that someone else may have responsibility, and you should ensure that you've got that in your document, or else you've got somebody in an ethical quandary where they're trying to get on the field and they're not allowed, and they feel that they're responsible, or they may be judged on that. Sorry, a question from the back here from Liz Jones.
Johnson.
Liz Johnson. Oh my God. Sorry. Sorry.
So I guess it just made me think, and maybe this is just part of in the recognize, remove, and staff education at our level, staff and coach, because I've been in a situation at a World Championship event where an athlete was concussed or potentially concussed. And I, following protocol, went immediately to the team physician and got completely ripped apart by the coach because I didn't go to the coach first. And the coach didn't want, and fair enough. I probably should have gone to the coach within the moment. It was during warm up. The athletes were having a very short time frame between the time where they're going to have to potentially race and or make a call to not go. So we're in minutes of making a decision. Was there an event or not? I had not, two people hit heads in a pool coming up. And so I think it's really important that everybody on the team is communicated together of what that protocol is. But then also, even knowing if that is the plan, how do we support the coaches or the staff in making sure that in the heat of the moment, when these things happen, how do we make that the best possible scenario so that the athlete gets to do what they can do and we're not causing a big disruption, I guess, in the plan.
Thank you, Liz Johnson. So essentially, for those that may not have heard it, a comment about important to know, when possible in the protocol, to know who to be communicating with if you observe something. Because sometimes if you're going directly to one practitioner and the team is expecting you to talk to someone differently, there might be people that are upset by the change in protocol. It's in here, and we'll get to that in a minute, but I totally agree. It is important for you to in your protocol, at the DTE or in competition, like who is the person, if you see something that you should go to first, but also like, what if they're not available, you know, like, cause if you name like the coach, but the coach is not at that practice for whatever reason, then, you know, who might that next person be? But it is a great point about, as we know, because there's many in this room that have worked in high performance sport. I think everyone here has worked in high performance sport. Sometimes there can be a bit of a hierarchy of who you're expected to talk to and who you're expected to not talk to, and that can raise the emotional level of it.
Versus what a medical protocol is could be different. And so then how do we thread the needle on and so say I go to the coach first and the coach says we're not reporting this, then I guess what.
You know, I don't have all the answers to ethical, ethical questions, but I think like essentially what you're saying is, what if people want to underreport? And I don't think there's an answer to underreporting other than to have a robust document or protocol that your sport can lean on. And I think the other bit is, you know, trust in the team. And there's not an easy answer for when that's not present. Yeah.
It's mandated that the coaches are also learning this protocol as well, like the sports side to make this concussion protocol, that it's just as important to make sure that the coaches are familiar with the protocol as well as the team staff.
100%. Yep. Yeah. Everyone, I mean, the whole thing around the protocol is, you know, to write it in language clear enough that everyone, you know, should be able to understand it. But, you know, the bit touched on earlier with the education is that everyone's also reading the same document. And so not that you'll be carrying it around with you, you know, at the sidelines, but it is, you know, like it's really helpful to say, well, listen, we all signed off on the document, and the document says if we observe what we just observed, that this is what's going to happen. And I think as a sport, you know, you want to be all on the same page about that, but be, you know, like the sideline emotional fervor tone, like I said, there's not an easy answer to, but at the very least, if everyone's read the same document, signed off on it, you're steps ahead. Because if you don't have a document, you might say, well, I think that's a concussion. Well, I don't know what you're talking about. I didn't say anything, and we don't have protocol that addresses the situation. I'm in charge here, so this is what's going to happen. And that can be really frustrating. And as you point out, put someone's health at risk. Now, there is a question here quickly about from Island MMA. I've heard some trends about CBD and helping heal concussions. What do we know about the ability to help heal concussions? And I'll admit the research out there is ongoing, but there is a Canadian researcher, Patrick Neary, who was recently here in Victoria, but he's based in Regina, who's doing a study on CBD and recovery from concussions. I know the study's just about to get started, so we probably won't have good evidence on that for a while. So that'd be my quick response to that question.
Presenting in January, and he'll have data next year.
Yeah, he's presenting on January on a different topic, but he is presenting in January, and I think his hope is that in a couple of years, this concussion recovery or concussion treatment study funded by the NFL on a big grant from the NFL will have some data in a couple of years. Yeah, it's and so you know, if we look at how to put this into your protocol, you know, so and some of this verbiage is from the Parachute Canada, their general guidelines. So talking about how the formal diagnosis should be made following a medical assessment, all stakeholders, including athletes, parents, teachers, coaches, teachers, officials, and licensed healthcare professionals are responsible for the recognition and reporting of athletes who may demonstrate signs of head injury or report concussion-related symptoms. And so, you know, following this up with, it should be suspected in any athlete with impact to the head, face, neck, body, and demonstrates any of, and so then you list, you know, there's physical symptoms, emotional symptoms, and cognitive symptoms. And so any athlete suspected of having these should be removed from play immediately and assessed by someone on the medical staff. And now I think the important part here is like, so the medical staff, but who is the medical staff? So when you can, I think, you want to highlight who these are and acknowledge it may change based on the DTE. So in our provincial Alpine example, if you're in Whistler, it'll be the team therapist, Riley, for immediate assessment. If Riley's not there, then they should be referred to the team physician, Charlie, or the athlete's family doctor, or the nearest medical clinic or hospital based on availability. So now you've covered off on, you've seen it and you know where to send them. After removal from play, the athlete should not return to training until they've had a full medical assessment. And so what this is just confirming that if you remove them, that someone's going to confirm the diagnosis and then set up the treatment plan. And when we're traveling, if we're at this training camp, it's going to be the CSI Calgary therapist, and we don't know who that is right now. Training camp B, we're sending therapist Finley F. And so that's who you're going to send to for any assessment. And at the competition, we're going to fall back on the LOC medical to do the assessment. And then, you want a blurb in here. If any red flags are observed, this might indicate a more serious injury, and you're going to call 911. And so I think, the message here is these are key bits to have right in your document, so there's clarity on what the next step should be. And so here's an example. Sorry, not example 3, but here's an example of a 15-year-old speed skater, part of a decentralized provincial program. He falls at the end of local club practice, and he's got obvious signs, so he's sent home from practice. He comes back a week later, still having symptoms, and he hasn't seen anybody. And so, what should be done here? And I think the key bit is that, it wasn't made clear in this case that the athlete actually needs to be assessed. And so the athlete just went home and rested and just thought they would get better and they would feel better and be cleared. But in the protocol, they can't come back to practice until they've been assessed. So in this scenario here, it's just a reminder that you want to have this line in here around ensuring that there is some kind of assessment that confirms the diagnosis and then confirms what we're going to talk about next, which is like the return to sport plan. So the on-site assessment. So this is like after you've recognized it and you've pulled them from play, you've sent them to Riley, the therapist. I think the key points here are the on-site assessment in a protocol can get complicated, because, well, we all like to think of there's the daily training environment and then you compete. The daily training environment can change dramatically, at the ski hill based on, is it Saturday and all the coaches are there, or is it Tuesday afternoon? Is there's one coach, or maybe kids are just going out with the S&C person doing something different. And so there's not as many coaches present, or there's not as many staff present. And so, you're obviously not going to be able to account for every specific scenario. But, to the best you can, you want to kind of account for the ones that maybe that you can control. And so I think, you want to consider a protocol for when team staff are there and another protocol for when they're not. And, the other protocol, really, you're just talking about if you've seen this and you're removed from play, then you're going to send them to the Emerge or a walk-in medical or some other medical clinic for assessment. And so in the protocol, so in the daily training environment, athletes will be assessed by the on-site team medical practitioner. In Whistler, this is team therapist Riley. And if Riley's not present, then they'll be taken by team staff to the medical clinic. And when we're at training camp, again, it's going to be the CSI therapist. When we're in Calgary, it's going to be Finley. When we're in Vail, and if training camp therapist isn't present, they'll be taken to the nearest medical clinic. And I've referred here as per the emergency action plan. And that's just a slight nod to when you travel with the team, you want to have an emergency action plan because stuff happens out there and you just want to know what to do next. And at the competition, again, we're going to leave the on-site assessment to the LOC. And so, it's also a great place to put a reminder about, like, if an athlete's suspected of having a more severe head injury, so see the red flags, don't look for Riley or don't look for the on-site therapist, call the ambulance and then look for somebody. So to not delay if you see red flags. Now, this case kind of will lead into what our next, the office assessment. And so this is a case Dr. Longland had about a 22-year-old rugby player, took an elbow to the head while he was playing for his professional team back in the spring, developed some symptoms, some headache, visual symptoms, irritability, brain fog, classic concussion symptoms. Most resolved quickly, but some symptoms persisted. A protracted recovery, but eventually did return to play, but he never felt like he was 100%. And then he had an episode of another illness that made him feel worse, but he was, cleared by the team physician. But because he wasn't feeling well, this athlete ended up pulling himself in the last 2 games of the season. And so, he returns to Canada. He's feeling better. Has been training on his own without any concerns. He has a pretty normal exam, and so the team physician, Dr. Longland, counseled the athlete, discussed the return to play, and had a plan about full training with the squad, non-contact, and progressing from there. The point that's raised up here is the challenge when there's more than one physician or more than one lead treatment practitioner involved here. The professional team doctor, has a different standard for concussion assessment and clearance. And so that professional team probably has a concussion protocol, and it may be different from the national team. And so, just to highlight that, if you're involved in high performance sport or in any sport, you might have kids and athletes on different teams with different protocols. And just, to acknowledge that sometimes there can be confusion about who's responsible. But at the end of the day, if they're on your team traveling to your event, you're in charge. And so in these reevaluate, so this is the office assessment, after they've had the field side assessment, and then they're going to see for the medical assessment before they can return to practice. You want to identify who that person is. And when you know the name, you put the name in your document. And who's acceptable if that doctor's not available. Like if the doctor's traveling or is on vacation, obviously you don't want kids just to sit around waiting for Charlie C to come back from his Hawaiian vacation. And then I think it's really important to clarify how the doctor will communicate their assessment. So is it going to be a letter that they write down and confirms that it's a diagnosis of concussion? Are they going to put a note in like the sport management database? Are they going to call somebody and tell them verbally? You want to account for this in your protocol so that it's clear how team staff are going to hear from the team medical staff about confirming the diagnosis and the management plan. So, just, again, another example here, Team BC Alpine athletes will be referred to our sport medicine physician consultant, Dr. Charlie. Dr. Charlie will see the athletes on referral from the team therapist or team coaching staff at his clinic. He'll confirm the diagnosis, or if it hasn't occurred, and clear the athlete to return. And if Dr. Charlie's not available, athletes are seen by the physician covering in his clinic or by their family doctor. And if concussion is diagnosed, this is what's going to happen. Dr. Charlie is going to call or inform the team coach, the team therapist verbally, and then document this in the athlete monitoring system. And then Dr. Charlie and team therapist Riley, they're going to confirm the concussion management plan. And if this happens while the team's traveling, the team's going to reach out to their doctor for guidance, and which may include that Dr. Charlie may want them to be seen by another physician, and review the return to training or travel home with the team staff. Now, you may decide on something different. If they're traveling, you're not going to bother Charlie because Charlie's on a small contract, or Charlie works really hard when they're in the DTE and he's going to have a break when they're not. And so, the protocol might look like if there's a suspect concussion, we're going to go to the hospital, or we're going to follow our emergency action plan, or we're going to, we have a consultant that works with us when it's travel. All those are acceptable, but it just becomes important that you've highlighted this in your document so that there's no misunderstanding when people are on the road what the next step is. Now, a question that came up previously is, what if you don't have medical professionals on staff? And so, I think most people in the room here work for national teams, and some people have some provincial sport involvement, but at the community level, you may not have any medical staff. You might have a coach and, a skills coach and a head coach. And that might be like a big staff for a community sport team. And so I think, at this level, particularly if you participate in high risk sports, all sports, it's their responsibility to figure this stuff out. Like if you're coaching community level rugby, you still need a concussion protocol. Pretend that concussions don't happen in 12-year-old kids. It's not a thing. It happens in everyone in every age group. People crash their bikes all the time. Doesn't matter how old they are. And so you just want to have in your protocol, acknowledge that we don't have staff. And so we're going to, rely on family doctors. We're going to rely on first aid organizations. We're going to, as an organization, you can reach out to therapy clinics, to physio clinics, or to medical clinics and partner up with them so they can help you with some of this concussion coverage in terms of assessments and clearance. And the comment that I make is you want to look for people in your community that have the expertise and the interest and the capacity. And it's, for every sport out there, there's lots of parents and they have their own connections. And usually it's possible to find clinics, that have medical staff or therapy staff that are able to help out. In the parachute documentation, they've also got a little blurb here on how to find the right doctor. This is so CASM is the Canadian Academy of Sport and Exercise Medicine, parachute organization, parachutecanada.org. Both of those organizations have a list of people that have expertise in concussion, and organizations can reach out to them to try and help identify staff that may be available to help with their sport. And so here's another case. Athlete has a fall, diagnosed with concussion, sport has a guideline. So it's pretty general, but it's not a protocol. And so in this scenario, the progress is slower than expected. And from the sports point of view, it's not clear who's tasked with monitoring the return to sport. And so what happens is lots of people are doing it. And then it becomes clear that the athlete has disclosed that the non-healthcare part of the team staff has been prescribing the treatment, recommending non-evidence-based treatments, progressing exercise faster than the recommendation. And it turns out this is why the athlete's taken so long to recover, because someone that doesn't have experience managing concussions is managing the concussion. And it turns out that person's, it's based on their friend's advice. And so, this is where it gets a bit complicated. And so it's better just to clarify, this is the person that's responsible for setting up the program. And that person can consult with as many people as they need to, and they should. But, when you don't put this into your protocol, then people kind of move into the empty space. And in this case, it was a coach managing the concussion return play. So the return to learn and return to sport key points. Dr. Benson mentioned it in his talk. It's really important that while both the return to learn and return to sport can happen concurrently or in parallel, a full return to learning, so people should be back at school before they're cleared to be fully back at sport. And, I've had an experience where an athlete was out of school for 6 months, but he was back in the sport for 4 months. And, just a little bit that I certainly think delayed their full recovery. And, athletes, they're often really motivated for the return to sport. They're not always have the same motivation for getting back to school. But it's really important that return to learn, getting back to school, it should be the first hurdle to clear. And it's, it makes sense as well. Like cognitively, if you can't manage sitting in a classroom, then probably cognitively, you're also not going to manage processing high bits of information like in the ice rink or on the football field or barreling down a ski. In your protocol, you want to specify who's going to clear the athlete to begin the return to sport protocol. And this probably should be part of even the reevaluation part of your protocol. You want to identify who's monitoring the protocol. So is it the therapist? Is it someone in the community? Is it the coach? Because sometimes if there's not a therapist, the medical practitioner might talk to the coach and they might agree on what, the prescription is going to be over the next week or two. And, as long as there's clear communication, that might work. And then you want to be clear about who's going to give the final clearance to return to sport without restriction. And I think this is the one thing that comes around to like where the legal ramifications of your protocol might come to bear good fruit or ill if you're not clear about who's giving the final clearance. And so athletes that get cleared early before they're ready, they are at higher risk of not just recurrent concussion, but like of other injuries. As mentioned in Brian's talk as well, we now recognize that lower limb injuries are elevated in the cohort of athletes that have had a concussion for the next 6 to 12 months. And so, we just want to be really clear about who is going to take on the responsibility for clearance. And, and I have to say that the return to learn and return to sport, the general return to sport guidelines of Parachute Canada are well done. So it's easy for sports to refer to those. So, give another case here. National team athlete sustains concussion in another country, returns to Canada. But again, not following the sports protocol, they're following the foreign doctor's protocol. They have persistent symptoms. And this is where, some confusion arises because there's not agreement about, is this concussion-related symptoms or is mental health-related symptoms? And then at the next national team competition, symptoms return. And then the athlete isn't reaching out to team staff, they're reaching out to the doctor in the United States but that doctor isn't communicating with team staff. And so it becomes really confusing and really, tense over the next few days over deciding who's got jurisdiction to decide what should happen. So again, really important to put all this stuff, who's responsible for final clearance in your document. So again, the protocol could look something like this. So here's the outline of a return to sport protocol. After the initial period of 24 hours of rest, they're going to begin the protocol. And so in the daily training environment, the athlete's going to begin the return to sport protocol by Dr. Charlie C. based on his office assessment. If traveling at a training camp or competition, clearance to begin the protocol may be given by the physician or remotely by Dr. Charlie in collaboration with the traveling team staff based on their assessment. And then who's going to monitor in the DTE? It's going to be Riley. When they're traveling, it's going to be the traveling team therapist. When the athlete's completed, the final clearance by Dr. Charlie C. If the athlete has new symptoms during the protocol, this is just the basics of return sport protocol. They're going back to the previous stage. And then, having in your protocol, just highlighting again how important it is for that youth student athletes return to full-time school activities before progressing to the final stages of the return to sport protocol. And I didn't highlight this. Maybe I should highlight it more, that it's also important to have this medical clearance letter, because I think if you have a letter that people are signing off on, then there's a clear line in the sand about, is the athlete cleared or not? Has the letter been signed? Yes, then they must be cleared. So we're getting near the end of this bit. So other considerations in your protocol, again, is confirming which athletes fall under the protocol. Is it everyone at training each day, or is it just athletes on the national team list or the provincial team list? Because sometimes people have training partners and they also get concussions and stuff. But it's important to know who's responsible for them in the concussion world around managing them. Because if the training partners are foreign, so not from this country, they may have an IST back in another country and they may not be following your protocol. So if whoever falls under, you want them to sign off on. That makes it pretty straightforward. And then what about concussions that don't happen during team activity? And I don't have the right answer for this. You have to decide on your own, but should all concussions and the athletes on your list, follow the team's concussion protocol? And my sense is that it should be yes. But it gets a bit tricky, if athletes play rugby and they ski and, concussions happen to rugby and the ski team has a different protocol around clearance. I mean, hopefully people are using the same objective markers, but just acknowledge that, your rugby athlete might do other sports and get a concussion in those other sports. Should there be mandatory reporting? I think most experts say that there should be. And then what are you going to do if people aren't progressing? I think you want to highlight what the options could be for the second opinion. Sometimes it's difficult. Teams are doing good if they have one doctor. They don't often have a cadre of multiple physicians, but so you might highlight, what are the concussion expert care clinics in town, and you could list them as potential sources for second opinions. So we'll just, how are we doing for time? Quickly run through this case here. This is Dana, who's a skier attending the BC Alpine Camp. And the athletes are working on their turns on a practice course. And on the hill there's athletes, there's the team coach, there's the therapist, and the team manager at the bottom. And so Dana has a fall near the bottom of the course, witnessed by the teammates and the team manager. Athlete appears wobbly, getting to his feet. And so what should happen next? So if you go by the protocol, multiple people have witnessed this athlete with clear physical signs, so they're unsteady. And so, you can make the diagnosis of concussion. So what should happen next is the athlete should be removed. And then the things that follow from that, following your protocol, you've removed them. Are there red flags? Is anyone available for immediate field side assessment? What's the physician you're going to refer to? Are there any immediate return to learn or return to sport considerations? And, so there's no obvious red flags. Therapist is on the hill so they can do the assessment. And then, the therapist can then refer to the team physician. The athlete's advised to rest at home until that appointment is confirmed. Sorry, I just kind of flew through that really quickly, but we're running out of time. So in summary, you just want to ensure that your protocol is specific information where possible. So staff roles, staff names, and again, you're reading it more like a roadmap so people kind of know what the next step would be based on what's happened. And so you want to consider in particular these specific points around prevention, recognizing concussion and removal from play, with the on-site assessment, who's responsible for that. And if you don't have team staff, what the plan is going to be in the absence of team staff, who's going to do the reevaluation or the office assessment, and what are the return to learn and return to sport considerations. And some great resources here with Parachute Canada. This is the CAT Online. It's a BC resource funded through the University of British Columbia. So let me know if there's any questions. Just kind of a quick.
Running the chat.
Yeah, so Jen is asking, are there specific recommendations you'd have for non-centralized or next-gen athletes? Yeah, I mean, obviously for decentralized athletes, they're not going to be able to see your therapist, for monitoring, or maybe see your doctor to confirm the diagnosis. And not only that, for decentralized athletes, like you're probably hearing about the concussion like a day later, it might be a week later. And so I think, the concussion protocol, maybe you write a blurb around what the expectations are for decentralized athletes, that they're going to be seen locally, confirm the diagnosis, and then, have whoever's assessing them provide a management plan. You might have a bespoke management plan that you can mail to them that once you've been diagnosed, this is what our expectations are or what our recommendations are. It is a bit challenging because you can see it can be different, because I've had this happen to me where someone's called me on the phone and said, hey, athlete has just fallen off the stairs and hit their head. What should we do next? And so that's a bit different than, hey, athlete, fell off the stairs last week and they've come to training and they still have headaches. We think they might have a concussion. Or versus like the athlete fell off the stairs, hit their head, saw a doctor, diagnosed a concussion, and now we think they're ready to return to play. And so you just want to consider all these different bits here. But I guess, Jen, to answer your question, I think you want to acknowledge that athletes that aren't in your training environment, your protocol needs to be a bit more lenient around who's going to do what, because you may not always have control over who's going to do what. And if you've got specific guidelines that you want them to follow, in particular, so Jen's from Rowing Canada, like you probably have a great return to rowing protocol that you could probably share, broadly. And I would say, Jen, if you guys do it, you should probably put on your webpage, because probably the provincial systems and other community organizations would love to, have some guidance on that. But, you just need to consider what you can control and what you can't. So, but the things you probably want to be clear on is what happens after the diagnosis is made, and then who's going to give the final clearance that they're ready to go. Any other comments or questions?
Some legal ramifications, but is Rowan's law only in Ontario?
Rowan's law is only in Ontario, but I think medical legally, if
we want to do the best thing.
Yeah, we want to do the best thing. Well, I can say this: if someone's under physician's care for anything, ACL, mental health, concussion, and the physician hasn't formally cleared them, and someone else does, and they go back and have a bad result, I think medical legally that person might be at risk depending on what their role and responsibility might be. And so I think Rowan's law as a law that is in place to ensure that mostly that teams have a protocol and that they follow it, and that the protocol, there's some specificities to it. But it's also, it's not meant to let the other provinces off the hook and you can, still the Wild West, you can do what you want, I think. And so that comment was more around where a team's going to get into trouble. Maybe you don't recognize it. Maybe the return to sport's too quick. Because those are debatable points. But if someone hasn't been cleared and they're asked to go back, I think that's the one place where people can really get into trouble. And that's personal opinion. Yeah. Okay.
Along similar lines, under reporting, that is coming into the environment. If someone does underreport, where would you capture in protocol the consent to share prior medical information with on the ground ISD?
Yeah, now, and so sorry, the question from Phil Dunn, the high performance director for Triathlon Canada, was about under-reporting and where in the concussion protocol you might fit things like sharing consent to share medical information. You know, I'd say from the national team's point of view, and my comments will, you know, directed in that form, because I think at the community level, you know, it's obviously a lot different. The first thing I would say is there is no easy answer to underreporting. Yeah, athletes that have a crash, don't tell you about it, show up practice the next day, tell you you're fine. You might, hey, you look a bit off, and they blow it off. Like, there's no, you know, there's not an easy way around that. I think having something like mandatory reporting, and so that if athletes disclose at a later date, that you might have like something to fall back on about what to do about athletes that are consistently underreporting. And I know that gets challenging because like concussion isn't the only thing that they might underreport, right? And it's, you know, can we compel everyone to share their medical information with us all the time? And I think the easy answer is no. But, you know, when the athletes underreporting affects team selection, right? So athletes not actually medically fit or healthy enough to compete, and they're preventing other athlete that is from getting on the team. I think that's where you can get into the idea that, you know, there needs to be some kind of agreed upon reporting about health status. Yeah, it gets tricky. But I'll say this, I don't think mandatory reporting needs to specifically be in the concussion protocol, but I can see it being part of the athlete contract for the national team. And where you lump it in with all the medical reporting around health status, you know, that includes all the different things that might go with there. And I know, like sometimes it's even like illness reporting before travel, those kind of things, you know, like, because that's a identifiable risk you might bring in. Yeah, it's tricky. And as you know, you might have it in there and athletes might still ignore it. And so I think the thing comes down to like, how do you enforce all that? I know, Stellingworth might recognize this example, but there was a sport many years ago where they struggle with athletes showing up injured at camps and competitions. And finally, the high performance director of the day instituted a rule that if you showed up and you couldn't compete, you had to pay for your travel. And it was actually on the books for a year or two before it got implemented very bluntly at one competition. And there was a lot of consternation about it. It didn't happen again after that, though. Athletes got a lot better about reporting, and which isn't me advocating that should be the case, but I do know, you know, we all have autonomy around sharing medical information. It is private, but when it starts to impact others that could be selected, I think that's where the sport has a rationale for requiring some kind of mandatory sharing, or yeah.
So any concern on duty care of a coach or any lead over the environment where an athlete comes in that does potentially demonstrate a compromised coordination or like that might deem them a danger in the pack related?
I think we always should be watching for that, you know, whether it's concussion or other health things. Like if they're in your environment and you think they don't look well, you know, I think it's totally within your right to, you know, arrange for an assessment, and base further decisions based on the assessment. You know, because one way to capture underreporting about health, like a concussion, you know, is like, oh, you seem a bit off. You could ask questions and we're just going to do an assessment about that. And, you know, the SCOT, like their basic stuff that's really can help with the diagnosis. And you can't make the diagnosis based only on that, but from it, you might realize, oh, like your balance is right off and your cognitive scores are quite low. And we have concern about putting you on a bike in a pack and riding around 40 miles or 40K an hour. As you can see, as we build this out a little bit, it still gets a bit tricky if the athlete's defiantly saying that they're okay. Yeah. And there's no easy answer to underreporting. Yeah. Any other questions?
Last one, Patty. I mean, while this was on how a sport could build out or a program could build out the protocols, I mean, what's our advantage as an institute? So maybe you speak to what we're attempting to do with regard to, you know, medical screening, and how is it going to impact this?
Great question, Dave. Thanks. So I think the advantage from the Institute is, you know, we do have physicians and other staff that are familiar with concussions. And so we can help with assessment, particularly the office assessment. We often have staff embedded with teams, and obviously they can be involved in the creation of the protocol, taking on some of the roles for field side assessment, removal of play, those kind of things. But I think probably the biggest thing I would say is, you know, we have the expertise to help with the office assessment, creating the return to sport management plan, available for, you know, the final clearance. And we also have the expertise to help sports create those plans so that they have their own staff following this. But, or sorry, I should say we can create it so they can have their own staff, even if those staff aren't CSI Pacific staff also. And there's another question on the chat. If an injury is reported within the sports club, can that information be shared with other clubs in BC? Yeah, Laura, that's a really great question. And it does come down a little bit to, you know, does the sport have a consent to share information agreement in place? And so with many teams, we actually do try and get athletes to sign a consent that indicates they're going to, like within the team, some of the medical information will be shared, you know, as it relates to managing athletes' health and availability for training or competition. Where it gets tricky, because I don't think any of the sports specifically have documents that allow the sharing of information between clubs. And so I think in that scenario, you know, probably your best approach is, you know, to talk directly with the athlete about the risk of leaving your sport and your protocol, going to another sport and pretending like they're okay when perhaps they're not. But I don't foresee that you be able in this, because it's a bit tricky to institute consent to share medical information within a team. Like it can be done, athletes consent to it, but it's, you know, they have to sign off on it. I think, you know, once you start to involve multiple clubs, it gets a bit harder to implement that kind of consent document. It would be what I would say. And I know maybe that's not a satisfactory answer, but I think probably the approach should be, you know, direct with the athlete and their parents or their other personal IST that they might have about the risk of going on to another sport and participating if they haven't been cleared for your sport because of ongoing concussion symptoms. Great questions. And I think if there's no more, I think we'll call it there. Thanks everyone for coming out today and asking some great questions. And we had some great chats here in Victoria. I appreciate everyone's involvement.